From the JAMA Network, this is JAMA Ophthalmology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Ophthalmology.
Hello, and welcome to this author interview from the JAMA Network. I'm Neil Bressler, Editor-in-Chief of JAMA Ophthalmology, and today we're going to look at Curcuma-Based nutritional supplements and their relationship to the risk of age-related macular degeneration. And joining me is the corresponding author for this investigation, Dr. Ehsan Rahimy. Dr. Rahimy is an adjunct clinical associate professor of ophthalmology at the Stanford University School of Medicine. Ehsan, thank you so much for joining us.
Neil, thank you so much for having me on the podcast. It's a pleasure to be here. As we were discussing earlier, I usually listen to it avidly on my way to and from work. So excited to be here.
Well, this should be an exciting one. So maybe you could just start for everybody listening. Maybe not everybody knows what curcuma-based nutritional supplements are. Can you tell me what these are and maybe some foods that might contain them naturally?
Yeah, definitely. So I just actually had some turmeric and ginger tea. This is, I think, something worth seeing is becoming a common theme amongst our health-conscious population is the incorporation of turmeric, whether it's as a spice, as has been seen in a lot of traditional like Indian and Southeast Asian cuisine. But again, we're seeing it incorporated now in terms of teas, other types of supplements, and really overall in an evolving Western diet as a lot of our patients in our society are much more health conscious and being more health forward and proactive about their care. So curcumin itself is the biologically active ingredient of turmeric. And so it's typically isolated from the plant Curcuma longa. And so again, as we will discuss, there are naturally existing forms of this that are incorporated in the diet, but then also, as we're seeing more and more often, is being used as a supplementation.
So what made you decide to investigate this supplement? Or for this investigation, were you looking at many? And is this the only one that had the most striking results?
That's a great question. And actually, we started this investigation with curcuma in mind. I think if you actually, for those who are unfamiliar, you do some research, this isn't novel per se in medicine. There has been a basis for the incorporation of curcuma-based supplementation, again, whether naturally in your diet or via taking it as a supplement in various fields of medicine. There's well-reported effects of this in terms of skeletal muscle, recovery, arthritis. It's a known and potent anti-inflammatory. It has antioxidant properties as well. And really across other subspecialties in medicine, we have seen in vitro studies showing anti-neoplastic activity, cardiovascular benefits in diabetes, and really there's been a scattering of literature over the years suggesting even beneficial effects for various ophthalmic conditions that we see, including macular degeneration. In the part of the country I live in the Bay Area, my patient profile tends to be a lot more health conscious. They're very proactive. They take their AREDs. They don't smoke. They do UV protection. And they're always just kind of looking for something a little more. And I think that's where the nidus or the inspiration for this type of study came from. We already know there's a host of risk factors for the development of AMD, things that are not in our control. Genetics play such a huge role. Age plays such a huge role. And then in the big gray area is your lifestyle. And so a lot of what we discuss with patients are typically avoiding the negative things, right? Don't smoke or UV protection. But can we get some bonus points from potentially supplementing with certain things? And we have AREDs at our disposal. And so curcuma has been another supplement that is being explored. Again, not to the extent that I would like it to, but hopefully this type of study serves as an inspiration for more work, as we'll discuss.
All right. So this makes a lot of sense as to why you may want to look at this for macular degeneration. This was a retrospective cohort study. So that means you looked back at records that already existed, but who were the people that you were checking? Who were these records from?
Yeah, so to conduct this study, we have access to a large federated aggregate electronic health records database. And the particular one that we use is the Trinetics network. At the time of query, there were over 147 million patients in this network, which gives you an idea of the sheer volume of patient lives that are encompassed within this research network. These patients span across over 60 healthcare organizations within the United States. This number is continually growing, and also globally. And one thing that's quite nice about the Trinetics network is you really get a nice heterogeneous mix of patients, very different patients in terms of gender, ethnicity, race, various backgrounds, as compared to the other type of large group of patients we'll get is sometimes population-based studies, but are typically isolated to certain countries. So then you have more of a homogeneous type of a patient mix. So we were analyzing the Trinetics network here. This is all retrospective. But as we will discuss and see when we go through the paper, there are really large sums of patients that are being evaluated. I mean, the numbers here are very difficult to ascertain via other mechanisms. That's what's quite unique about this network.
So as I understand it, you're going to identify in that group then people who have macular degeneration, those who don't have macular degeneration, and then perhaps you're going to try to connect who's taking these supplements and who isn't. And what did you divide out and what did you find?
Yeah, it's a great point in terms of an intro to our methodologies here. We attacked this question several ways. So the first way we did was to just look at patients who are taking Curcuma-based nutritional supplementation. And we had about 66,000 patients that were in the network. And part of our criteria was, as you know, documentation of medications can be a little bit loose sometimes. We have no great way to ensure compliance or know exactly what type of curcumin supplementation, what's the dose that this patient is taking. So we can't get that granular. I think that's why we were quite careful in our study to just grouply label this as CBNS, Curcuma-Based Nutritional Supplementation, just broadly. And we were able to require, though, at least 3 instances of documentation at the time of index and 2 additional ones over the ensuing 2 years for longitudinal follow-up as our best surrogate to ensure that a patient is taking this longitudinally. And so this first study we did, at least our primary study, was seeing the development of macular degeneration, be it non-exudative, progression to advanced stages of non-exudative, also known as geographic atrophy, progression to exudative disease, need for intravitreal injections, and progression to legal blindness. And these were kind of our outcome measures for that first group. And because we didn't want to just have this be descriptive, we would ideally like a control to compare to. Your gold standard in studies when you're doing randomized control studies is you're going to have your control group. When you have large aggregate data such as this, we don't have that. But this is where propensity score matching comes into play. And we can specify various features, be it, again, age, gender, ethnicity, systemic comorbidities such as hypertension, hyperlipidemia, smoking status, various things we'd otherwise determine to be confounders. And we can control for that and create a synthetic control group. That's what propensity score matching is doing. And we're seeing an emergence of these type of studies, I think, in our ophthalmic literature. But at least we can then directly try to compare the outcomes from our study group to that. And as a second analysis we then took patients who already had early macular degeneration, who were on Curcuma-based nutritional supplements, and compared them to patients with early AMD that were not taking these supplements and evaluated their outcomes to, again, advanced dry AMD or exudative disease.
Now, before we get into what the risk was, and was it reduced or was it actually increased by taking these, because we're going to get to your results in a minute, I know that just a few months ago, the same cohort was used by another group looking at melatonin use and seeing if that reduced the risk of macular degeneration. They found that it did. Were you able to incorporate their recent findings with this propensity score matching or control in some way? Because now I'm thinking, well, maybe people who take melatonin happen to like this supplement as well.
That's a wonderful point. I'm glad you brought it up. I think potentially a lot of the viewership is familiar with that study. It generated quite a bit of interest. It was done by our colleagues over at Cleveland. And yes, they found that melatonin supplementation was associated with reduced risk of progression of macular degeneration. They did utilize the same Trinetics network that we did. In fact, the study designs are fairly similar. And to get to your question, we did account for this. This gets back to what I mentioned with propensity score matching, because again, that's something that's of interest to us. Ironically, both groups were independently inquiring about their respective supplementation and without real direct communication with each other. So when we saw that that had come out, we realized we should also try to control for this. I bring that up because I think it highlights some pearls and pitfalls about propensity score matching. At the end of the day, nothing is a substitute for a true randomized controlled trial. In these types of studies, because we are so interested in analyzing large data, this is the best we can do, is to propensity score match. It's not perfect, though, because with propensity score matching, ultimately, you're only controlling for what you specify. There are still potentially unknown confounders out there that we are not controlling for. It's always important to keep that in the back of our mind, especially with the limitation to these types of studies. But at least in our analyses, we did control and balance for the use of melatonin in both groups, the Curcumin-Based nutritional supplementation group, as well as the patients who were not taking this. And so they were fairly balanced to at least mitigate any potential confounding impact from melatonin. Along those lines, we also accounted for the ingredients of AREDs. At least within this system, we can't just type in ARED supplementation. We would have to type in the individual components, lutein, zeaxanthin, et cetera, which we also did control for as well.
Okay, so putting all of those together, what did you find? Did this reduce the risk of macular degeneration, and what was the magnitude of it?
Yeah, so we saw quite a dramatic reduction, in fact, over the follow-up period, which on average was over 3 years for these patients from the index point after they had started supplementation. Similar to our colleagues who had run their melatonin study, we actually broke down patients by their age. So we looked at groups 50 years and older, 60 years and older, 70 years and older. And really across all the age ranges, we did see decreased rates of developing AMD, progression to dry AMD, geographic atrophy, conversion to exudative disease, as well as need for intravitreal injections. And by the way, the sample size here was, again, fairly large. There's over 66,000 patients in the treatment as well as the control group. When we got to the group that had pre-existing early AMD, the numbers, as you would imagine, became less. We had a little bit over 1,000 patients. But we saw similarly there was reduced rates of progression to advanced dry AMD, although we did not see as significant a difference anymore with the conversion to wet AMD. In terms of the magnitude of the risk reduction here, it varies, but for example, in terms of reduced progression to GA, we saw almost 1/10 the risk in the patients who were taking Curcuma-based nutritional supplementation. For conversion to wet AMD, it was about a quarter of the risk. And need for intravitreal injections was about 1/5 of the risk. So it's a magnitude order less on the patients taking these supplementations.
So the reason I asked about the magnitude is when I read this, one thing that stood out was, isn't that interesting? Here's a potential factor that might be related to the risk of macular degeneration, but then the magnitude was so huge. Sometimes when we see that, we do wonder, as you have rightly cautioned us, maybe there's something else going on. How do you rule out that it's just not super healthy people? Like you said, you're in an environment where a lot of people are outdoors, they're exercising, they're eating diets that perhaps are very strongly recommended for general healthy nutrition. How do you rule out that it's just a healthy person who happens to be taking that, but it's everything else they're doing, not this? Or can we not rule that out?
It's a fantastic point, and the truth of the matter is, you're right, we cannot rule that out. And we discussed this possibility in the discussion point that healthy user bias is potentially something that's very real here. We've seen it affect numerous other studies throughout medicine. There's this concept that your healthy type of patient is going to be the one that's potentially interested in seeking out these type of supplementations, and maybe they're taking even other supplementations, and they're really kind of over the top, leading to just an overall very healthy lifestyle, because we do know that these type of aggregate lifestyle decisions you or I make do play some role in the development of just disease overall in the body, but especially with macular degeneration. But to that point, I'm always very, especially with our trainees, our residents, our fellows that work with us on these type of studies, I'm very careful that we never overstate our findings. we're not here, especially in this type of study. I'm sure it's going to generate a lot of interest, and I hope that it does, but this is not cause and effect. This is merely hypothesis generating. And I consider this type of work with trinetics and similar studies, this is almost like foundational research. This is a building block. I think we see something that's potentially exciting. We have other literature to corroborate it. There are scattered studies some other colleagues of ours have done in the field that have shown, for example, with small numbers, of course, but reduced macular drusen volume over several years of use. Just ironically, I think 2 days ago, our colleagues in Duke just published a small series of patients taking oral curcumin as PVR prevention in high-risk RDs. So, I think the signal is there. It behooves us to follow this up, though, with more rigorous studies, more studies that can better define what the benefit of this is, what would be the dose, what type of supplementation we need to take. We haven't even gotten into that yet. I mean, when you look online or you look for sources like WebMD or other patient-facing educational materials online, the advocated dosage, at least that you can safely tolerate of curcumin, is quite variable. You could potentially take up to 8 grams a day. It's fairly safe, if someone is considering this, to discuss it with their primary care doctor. But there are many ways to adjust what is ultimately limited bioavailability of this. I think that's been the challenge with curcuma-based supplementation, is to truly harness its therapeutic potential. It has very limited bioavailability, and it's rapidly cleared from the body via the hepatic clearance systems in the body. So there are a number of strategies to kind of target that. And, we know other groups are interested in exploring this as well.
When you mention safety, I always think back to the beta-carotene days when that was a supplement that people thought maybe could prevent lung cancer from the epidemiologic studies done in that day. And then when it was subjected to a randomized trial, it was actually harmful. It increased the chance of getting lung cancer. So what would you say we know from your study about the safety of this? And should we await randomized trials that may help us identify a true cause and effect benefit and potentially any harms or safety issues to be aware of with this?
Yeah, absolutely. And I will repeat that point. We cannot draw any definitive conclusions here other than I consider this an interesting finding. It's a very large number of patients. It corroborates other studies and work we have seen in our field. So to me, that means let's explore this further. Let's set up something more definitive, which would be potentially multi-center prospective trials to better evaluate this. We have colleagues at other institutions that do want to explore this collectively, and I hope that we do that. That's where we'll get a better assessment for this in terms of what's the optimal dosing, what's going to be the true safety of this, and ultimately what will be the efficacy to it. I'm already getting some questions because, at least anecdotally in my clinic, some patients that come through that are interested in optimizing their macular degeneration regimens, at least I advocate for incorporating it into your diet. You can get turmeric supplementation. It can be used as a spice. You can safely use it in cooking with tea, as I alluded to. That's how I consume mine. I'm not necessarily pushing for much higher doses of use at this time until we get, I think, better understanding, better basic science studies, especially in terms of how curcuma interacts inside the eye.
That may be wise. So we so appreciate your sharing this information with us, and maybe we will see some randomized trials. I know the Trinetics cohort is not a population-based group. They may have these distinct features, but do you think this will get explored in other large cohorts, or is it time right away to move into a randomized trial?
I think that's always a great idea. And I think, our group has done quite a bit with the Trinetics network. In fact, I think it was late last year, you interviewed my co-author, Prithvi, from one of our other studies. So I think as we've evolved and used this over time, we've learned so much, but I think there's great value in trying to validate findings we see from these studies on other networks. There are other aggregate administrative electronic health record systems out there. And if we can repeat methodologies and see similar findings, assuming it's with different patient populations, I think that adds some level of confidence to the findings and at least the direction that we're going. Obviously, keeping limitations in mind again. In these types of studies, whether it's Trinetics, whether it's IRIS or other ones, we are largely trusting the utilization and proper utilization of ICD-10 coding, CPT coding. We're really trusting the user on the other end. And we can't get as granular with the individual level data as we'd otherwise like. So it's always important to keep those limitations in mind.
Well, thank you for that very balanced, cautionary discussion of a very exciting epidemiologic study. We've been listening to Dr. Ehsan Rahimy, who has a recent retrospective cohort study with his colleagues at Stanford University that supported the possibility that curcuma-based nutritional supplementation might reduce the risk of age-related macular degeneration. Now, this may need to be confirmed in other cohorts, and Dr. Rahimy was careful to point out to us this does not in any way prove a cause and effect relationship. It's possible this could just be healthier individuals that were taking this. But it certainly gives us information to think about for a major public health problem, macular degeneration, and ways that we might be able to look into reducing the magnitude of vision loss from this. Dr. Rahimy, thank you so much for sharing this with us.
Neil, thank you so much for having me here. It's been a pleasure and an honor, and hopefully we'll be back in the future.
Fantastic. This episode was produced by Daniel Morrow at the JAMA Network. And to follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.